Support Microbe TV. It's time for our annual fundraising drive. We depend on your support to produce high-quality science videos and podcasts, and now is the time to help us. If our programs have appealed to your science interests, or if they have helped you in some way, please record a brief audio or video with your phone and tell us about it. Let us know how we empower your inner scientist. We'll use it for our fundraising efforts. Send it to incubator@microbe.tv. And for more information on how you can give us your support, go to microbe.tv/contribute. This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1178, recorded on December 26, 2024. I'm Vincent Racaniello. You're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Daniel, our last broadcast of 2024, right?
This is actually an exciting one too, Vincent, because it's that weekend right between Christmas, during Hanukkah, Kwanzaa starting, New Year's is coming up. So you're going to have all the family together listening to TWiV.
Yeah, and they exchanging their microbes.
Exchanging their microbes and, discussing all the topics that we discuss. So,
especially, speaking of microbes,
and donations. Don't forget that, Vincent.
Oh, yes. They'll be writing their checks. It looks like you have some bacilli on your tie. Am I right?
This is the waterborne pathogens. So there's a whole bunch of different microbes.
Do I see some rods down there at the bottom?
Yeah, some gram-negative rods. There's even like a little round, probably sporidium,
Is there a cholera on it?
I actually just recently saw a gentleman in southern Zanzibar with cholera, where they still have cholera outbreaks. But yeah, there should be cholera on there. There should be norovirus, winter vomiting, disease pathogens. So, but all right, let's jump into it. And I was thinking about this earlier today. We've done over 300 quotations. Did you know that? Because we've been doing this. It's coming up on 5 years. But here's one that I recently ran across.
You could write a book, Daniel's quotation.
Someone could do that. Someone could compile that. That would be great if someone wants to do that. So, all right, but this is a Richard Adams. This is from Watership Down. I have to say, what a great book. Even there's a, Donnie Darko connection there. But many human beings say that they enjoy the winter, but what they really enjoy is feeling proof against it, right? So no one likes actually being freezing cold, but there's something about being dressed warmly, or maybe warming up by a fire. So.
I think there's nothing good about winter except snow.
I was thinking today about this, and we try not to be political, but I was asking my wife, if we move the elections to the spring, would it affect the outcome of elections, right? Because we vote, in the beginning of November, it's starting to get dark. We're losing daylight. No one believes in global warming. If anything, we're kind of wishing maybe global warming would help us a little bit in the dark, cold days of November here in the Northern Hemisphere. But if we voted in June on a nice spring day, maybe in August when it's oppressively hot, it might actually affect, our voting.
It might. I don't know which way. Who knows? Right?
Maybe a little bit of optimism. I always feel a little bit more optimistic and positive on a warm spring day.
Definitely. But, snow is very nice as long as you're warm, right?
Well, it was very nice for us this year. It's been a while since there's been snow on the ground during the winter holidays, right?
Yeah, White Christmas. I haven't seen one in ages.
Yeah.
So I even went and looked up the lyrics of the song to see what that was all about.
I've been dreaming about it.
I've been dreaming of a White Christmas, just like the ones we used to know, implying that we don't have them anymore. And that's pretty much true. I can't even remember when. When I was a kid, there was always snow on the ground, it seemed. Right.
Yeah. I wonder how much of that is our memory, because just think about when that song was written. Right. So.
Yeah. I like the line that goes, May your day be merry and bright, and all your Christmases be white. I like that. Have a merry and bright day. Isn't that great?
Yeah, that is nice. I like that. All right. Well, we've got a lot to cover today, and we're going to be talking about whooping cough. That is pertussis. It's the same thing. Polio kind of made it on the docket right at the end. Bird flu, a little bit upsetting news there. And actually a lot about vaccines and long COVID. So this will be a chance for everyone to have those discussions gathered together as a family. So yes, whooping cough or pertussis, they are the same thing. We read the headline, whooping cough cases reach highest level in a decade. The U.S. has recorded over 32,000 whooping cough cases this year, compared with around 5,100 as of mid-December last year. That's a big, that's a big change. That's a six-fold increase. And I've got a nice chart here from NBC News. But, really numbers had come down in mid 15,000 range. Then we have this drop in 2020, 2021. What do you think was going on there?
Look, pandemic.
Exactly. Wearing masks, a bunch of other things are going on. And it really has come back to, over 30,000 this year. So,
Daniel, I told you my story. When I was 8 years old, I went to Italy and visited my father's parents in a very remote little town. And they made me sleep in the room with a kid who had whooping cough. But they said, it's okay. You're vaccinated. You'll be fine.
Yeah, it'll be fine. All right.
The cough was unbelievable. I've never heard anything like that.
Oh yeah, and it's a characteristic. It's not diagnostic, but there's a characteristic whoop to this cough, and the coughing can get so severe you can't even get a breath in, and next thing you know, you're vomiting. This post-tussive vomiting, which is suggestive, I should say. So what's going on? So we don't have complete data for this year yet, so you kind of have to go back a little and see what's going on. But one of the things I was looking at is, one, and I think this is really important because we're going to talk about vaccines a little, is who gets pertussis and who ends up hospitalized for pertussis, right? So I was talking to the best man from my second wedding, which I guess implies I was married once before that. And Tony Dewing, who's a cardiologist, was saying, everyone's so, concerned about vaccinations. Why don't we just wait a little, And I was like, well, one of the problems, as we see here, is if you look at the reported pertussis cases and percent hospitalization by age group, we actually see the highest burden. So the highest, number per 100,000 is actually in the less than 6-month-old kids, and about 1 in 5, so over 21% of those kids end up in the hospital, right? So it's really a problem, right? We recommend starting and getting those kids vaccinated for diphtheria, tetanus, and pertussis. It's that diphtheria, tetanus, acellular pertussis, so the DTaP. You start at 2 months and then 4 months and 6 months, right? So you're trying to really start getting the immunity in there, because if you wait, it's a problem, because it's the youngest kids that are at the highest risk. The highest, percent are going to end up in the hospital. So it's 2 months, 4 months, 6 months. Then you get another booster, 15 to 18 months, and another at 4 to 6 years. So that's one of the issues with waiting. And do vaccines work? And I think you can also look at the same data. I'm going to leave a link into this. And if you look at, what percentage of these folks affected actually have completed that primary series, right? So by 6 months of age, you should have completed that if you follow the recommendations. Only 28.9% have actually completed that primary series. Even when we're looking at 6 to 11 months, 38.2, we're looking at 1 to 4 months. So most of these kids that are severely affected, they're not vaccinated. They're not getting those vaccinations. So just a couple issues. Vaccines work, and why there's this this encouragement to really, start protecting right as kids enter this world. Now, the next is recently was sent my way. Well, couldn't have come sooner, because it was yesterday morning. We're recording this Thursday, so it was Wednesday morning that this was announced, that an Israeli teen diagnosed with polio, health ministry investigates. And what I really liked, I actually sort of did a screenshot of this from jpost.com. The primary way to protect children from paralysis is through the inactivated polio vaccine, the health ministry stated. And I like that, Vincent. Why weren't they just pouring in some more of the vaccine?
No,
the oral
the
polio.
OPV causes polio. IPV is the way to go for sure.
Yeah,
Israel has done IPV only for quite some time now, like many other countries.
yeah. So
They don't tell you what serotype this was in this child, right?
I don't know if we know yet. And actually, that was what they were saying. They're doing testing. So we have a case of polio, which means that this individual has some degree of paralysis. So we don't know the degree yet of the flaccid paralysis. We also don't know, and we suspect this was another case of vaccine-derived polio, right? Because they've been administering a lot of the vaccine in the region in Gaza. This child was unvaccinated, which is recipe for disaster here. So thoughts, Vincent?
Well, it's not surprising. The child was probably not vaccinated or under-vaccinated, I would guess, because if you're vaccinated with IPV, you're protected against paralysis. And I think it'd be really interesting to see what virus this is. I would suspect it's derived from NOPV2, which was given in Gaza, remember, back in October, November, for trying to prevent paralytic cases.
Mm-hmm.
And more recently, environmental sites in Gaza have tested positive for polio too. So I think if it turns out this is OPV derived, it gives more ammunition to the idea of admitting that NOPV2 is no better than OPV2 and that we should move over to IPV because the OPVs don't prevent transmission. And so we might as well use IPV.
Yeah. And I think, I got to say, people who are not swayed on this, we keep introducing this. And I really, what a bad situation where, a child ends up vaccinated. And then this is now in the community. And I think we do know this was an unvaccinated 17-year-old who's now got some degree of paralysis. And, we're introducing this instead of, I think it's one of those, what is it, penny wise, pound foolish, not really switching over to IPV and just making this happen throughout the world. So.
Well, it's hard for them to admit that they made a big mistake and they're wrong.
Yeah, that might be the hardest thing. Yeah, I was watching a video just yesterday that someone sent me, just how wonderful the oral polio virus and how much better it is now that we have this novel one, but we're still paralyzing.
That's all fallacy. That's all wrong. Yeah. It's not so much better.
All right. Well, I also want to share, we have this new, I don't know if you saw this, Vincent, but we have this new HHS, Human Health and Services, Let's Get Real campaign. And so I'm going to leave in a bunch of links. HHS launches Let's Get Real campaign to highlight facts about childhood vaccines and share stories from confident parents who vaccinate their kids. So there's a news piece, and then there's a link to the actual Let's Get Real campaign. So in the news piece, they explain that the percentage of U.S. kindergartners with an exemption from at least one vaccine increased in the 2023 to 2024 school year to 3.3%, the highest percentage ever reported. One takeaway I'll take from that is this is still a fringe movement, by the way, right? 3.3% is certainly not mainstream. You read the media, you think everyone is stopping vaccinating, but 3.3%. In the 2019-2020 school year, only 3 states reported vaccination rates below 90%. That sharply increased to 14 states in the 2023-2024 school year. So we're starting to see this, anti-vaccine thing spread.
Daniel, once a vaccine scientist told me that the medical exemption rate should not exceed 1% in the U.S.
It really shouldn't. Yeah, it really
3.3 is wrong.
Yeah. Now, and this is, we'll read on further. I really like this because it gives some numbers. So if parents stop vaccinating their children, preventable diseases typically not seen in the US, they say can, they're going to come back. It's not a question of can, they will come back. And they highlight measles, where they say measles, for instance, it's extremely infectious and potentially very serious illness. Before the measles vaccination program began in 1963, an estimated 3 to 4 million people got measles in the US each year. About 48,000 of them were hospitalized, and 400 to 500 each year died. These numbers dropped dramatically after widespread measles vaccination and prevention efforts. But despite the success of the measles vaccine, measles cases are increasing again because of declining vaccination rates. And in this year alone, there have already, 283 cases of measles in the US reported to the CDC. And as we mentioned, these are in children, and the majority of those children ended up in the hospital. And so they've got some great, I love the graphics, right, of the cute little girl there with her purple Band-Aid on from where she got her vaccine. Of course, she's smiling. I don't know if that was staged. My kids usually never smiled right after they got a poke in the deltoid. But, and I particularly like, they've got a bunch of pages you can go into, and I particularly like the real science behind childhood vaccines. A couple of things we talked about today. We started with the fact that you really got to start young, because if you wait, you're going to miss that window when kids are the most vulnerable and when they really, need this protection, right? So that less than 6 months period of age. We won't talk about it today, but hepatitis B, this idea that, let's just wait. Well, we tried that. Let's just wait and target risk groups. And about, a third of the hepatitis B cases were being missed with that. So don't try to reinvent the wheel. Just ask what have people done before. But one of the big arguments you hear is, oh my gosh, all of these different vaccines, and they start counting on their fingers. And this is this question about multiple vaccines being safe at the same time. And they point out here that every day your child will encounter as many as 6,000 antigens just by being a kid, right? So put that, it's like, oh my gosh, you're going to be overwhelmed by all these vaccines, right? So even if your child got 4 vaccines at once, they talk about this 276 antigens. So just put the 6,000 just by being alive and being a kid out there in the world. And then, we're talking about 276 antigens from the vaccines.
It's such a nonsense argument, such a trope, right? These anti-vaxxers, too many antigens, just shows ignorance. And the fact that most people are not going to challenge that statement, right?
It sounds like, and I think that's what you really have to watch, is they say, I've seen kids and they were beautiful and wonderful, and then they got the vaccine, and now we see these problems. Kids develop problems at certain ages. They're much more likely to develop problems if they don't get these vaccines. We've talked about hundreds of kids now, getting measles, ending up in the hospital. Now we're talking more and more about children being paralyzed because they're getting polio, something that used to just be such a terror throughout the world, which we're at risk of. These numbers, maybe we should wait. We talked about the risk there. Maybe we should give smaller doses. Well, that just doesn't work, right? That's just, you have to actually get the right dose. Like think about antibiotics, like, we're just going to give tiny doses. Well, that's a recipe for disaster. The vaccines, the actual dose has been studied, and the dose is appropriate. The timing is appropriate. So really be careful about, what sounds like, I just want to be safe versus I'm just using rhetoric to undermine confidence in vaccines and public health.
I don't know who's going to be the director of HHS, but I hope whoever is leaves this up, right?
I think that's the challenge. So what's the timing here? What motivated? This should have been going on all the time, by the way, HHS. So I'm glad you've awoken from your dogmatic slumber. All right. Just making friends there. Okay. Avian influenza. This I found quite upsetting. So this was a headline: 20 big cats die from bird flu at a Washington sanctuary. And then more of half of the cats at this sanctuary in Shelton, Washington died of the virus over the past several weeks. Really what got me was, maybe I'm an animal lover, but I'm sure a lot of our listeners are. So we read in this article, in addition to the half Bengal tiger named Tabby. And in the article linked to, you can actually watch some archived footage of Tabby, animal enrichment with this ball and a water feature. But in addition to the half-Bengal tiger named Tabby and 4 cougars, Hooligan, Holly, Harley, and Hannah, Wyoming.
Yeah, it's a take on Hannah Montana, isn't it?
I think it's a play. The dead included an African caracal named Crackle, 2 Canadian lynx cats, Chucky and Poochub, a Jeffries cat, Mouse, I guess, a Bengal cat, Pebbles, a Eurasian lynx, Thumper, and 4 bobcats and 5 African servals, according to the sanctuary statement.
It's too bad. These are very nice animals.
They're beautiful animals, and you could just I've got a picture, and this is Blondie, an African serval, and you just sort of look into the eyes of this little cat there, and just this is, people keep asking, should we worry about avian influenza? Well, yes, yeah. And we'll talk a little bit more about how they're dealing with the millions of chickens out in California, and if the way they're disposing of those is safe. So we'll kind of.
I don't know if most people like animals or not, but you should. It's part of the ecology of the planet. I mean, these were sanctuary animals, but nevertheless, when you say no one is safe until everyone is safe, I think we should include non-humans as well.
I certainly do when I say that. I mean, just think of like people, their dream vacations. They go somewhere, maybe like I recently came back from Africa, and seeing giraffes and lions and zebra. I mean, I think most of us really enjoy animals and just knowing that they're out there. All right. Well, for the human animals, acute respiratory illness activity, we are in the thick of it. In most of the country, we're at moderate or high. Only a few areas where the acute respiratory illness activity is not at those levels. But let's break it down. So flu is here. Influenza A is here. And we have influenza A high activity throughout the country. And looking at wastewater data, you can see a lot of areas, some areas where it looks like we're at high or very high. So really full-fledged. The influenza maps I show from the CDC are always a little bit behind. But you can see out there in the West Coast, we're at high or very high activity areas in the South. Basically, the activity is on the way up all across the country. And I do want to talk about this article, which I think is very telling, because it's always important to ask, does this match what I'm seeing? Anecdotes can be a challenge. And so this is the article, The Burden of All-Cause Mortality Following Influenza-Associated Hospitalizations, Influenza Hospitalization Survey Surveillance 2010-2019. And this is published in CID. And this is one of those things, practicing clinician, for instance, taking care of patients in the hospital with flu, has a certain experience. Maybe 1 in 50, maybe 2% of my patients die, and then I send them home and quote unquote, they then do well. Well, is that the case? We've talked a little bit about this with COVID, where you may send them out the door, but what happens in the next month, 2 or 3? So, people are often interested in how deadly different infections might be. And I remember lots of discussion about what the infection fatality rate was versus the case fatality rate with COVID, right? And so this is this distinction. Someone gets infected with COVID. We may or may not recognize that. They may or may not get a diagnosis. They may not be recognized as a case. And then you have recognized cases where they've actually been diagnosed, they had a test done, and then what's the percentage of the cases that ended up dying? So there's a little bit of difference here. And then we're talking here about not only cases, but recognized cases that required hospitalization. So these folks end up in the hospital. So here, these investigators are looking at how many people who ended up hospitalized die from the flu, and not just while they're in the hospital. So let's go through the data here. And here the investigators looked at 121,390 cases hospitalized with laboratory-confirmed influenza over 9 seasons. And what percent died? 5.5% of these folks end up dying. That seems like a lot, right? It seems like more than 1 in 20. So let's start here. So we've got a case fatality rate of 5.5%, but then we're going to look a little more closely. So they report that 76% of the cases, most of the cases, were in patients aged 65 years of age or older. 71% were non-Hispanic white. 34%, about a third, had 4 or more underlying medical conditions. But this is where it gets interesting and what I was sort of, wanting to discuss. Among all the persons with an influenza-associated hospitalization who died, about half, 48% of deaths occurred after hospital discharge. And the median number of days from discharge to death was 9. So these people, they're in the hospital, we send them out, and an average of 9 days later, just as many people as died during the hospital stay are going to die post-discharge. Now, the post-discharge deaths more often occurred in older patients and among those with underlying medical conditions. Of 37% of the patients who died, only 37%. So only about a third of these people actually were attributed to influenza on their death certificates. So sort of an interesting issue, right? A lot of these folks, we've talked about this, they were in the community, they got flu, they ended up in the hospital, and what's actually happening about 9 days after they end up out of the hospital, they end up having a cardiovascular event, and that's actually what gets coded if you don't look very closely at the cause of death.
So it underscores the fact that when you talk about case fatality rate, you have to always take into account the sex of the person, because for COVID, men died twice as often as women, and the age, it goes from very low to very high. And where you are in China, for example, early in the pandemic in Wuhan, you had very high fatality rates, whereas outside Wuhan, it was lower because the hospitals were not overwhelmed and they could take care of the patients. So all these, nuances factor into it. There's not one CFR.
Yeah, and that's really a challenge, right? Because people always want to know, and there were, all these Hopkins trackers that people were following. And it's really tough. Yeah, what is the case fatality rate? I mean, what is the case fatality rate in hospital? What's the case fatality rate if you follow these folks out another month or two? What's the case fatality rate, whether you're in surge conditions or not? Even some of the issues with the different variants, right? I mean, early on when folks were using hydroxychloroquine, we saw about a 20% mortality rate because we were doing harm with that medication. We saw steroids being used at the wrong time in the wrong doses. We saw then, when the Omicron hit Hong Kong, right, in this largely unvaccinated population, we saw about a 4% case fatality rate within 30 days, which was as high as it was getting anywhere during, always really tough to track down and compare these.
This is a very good point. This hydroxychloroquine killed a lot of people, and a certain individual forced the FDA to license that, and there are no consequences for that behavior whatsoever.
And a certain person published a fraudulent article, right? Which we now, we talked last week. Some of the co-authors withdrew. The data was fudged. It was manipulated.
But still, no clinical trial was done in the U.S. And it was approved by the FDA. A dark spot on their history.
Yeah, no, clearly a dark spot. All right. If flu wasn't enough to get you, and I was consulted on a couple flu admissions today, so we are seeing this. Also got some calls today to see some folks with RSV. So RSV activity is also high. And a couple of different ways to look at this. One is the most up-to-date wastewater tracking where it's high. You can also look at hospitalization rates per 100,000. And we're clearly on that exponential rise at the moment. And activity has followed that typical pattern of being high, sort of sweeping up from the south. COVID, oh my gosh, 3 things at once. This is a triple-demic or whatever they want to call it. SARS-CoV activity in the most recent updated wastewater is actually high across the country. So, and we're even, I would think of this as a late indicator, but we're already starting to see certain states with a 2 to 4% of all the deaths are already due to COVID. We see that out in is that Arizona and up there in Minnesota. So sort of follow that over time. And even the sort of delayed wastewater from earlier like mid-December from the CDC, we're already seeing exponential rise in most of the country. So we're headed well towards another peak, as one of the two of us predicted in January. So we'll see.
It's delayed. At least it's delayed.
At least it is. Yeah, at least it's a little delayed. Unfortunately, everyone's all gathered around right now. So sort of the perfect storm. And you know what, Vincent, the only reason this is happening, this has nothing to do with human behavior and the fact that it's winter. It's all about the variants, isn't it?
Yes, of course.
Yeah, I say that tongue in cheek because the variants are kind of doing what they're doing. Not much really going on there. You know, KP .3.1.1 is being slowly outpaced by XEC. But no, this is really, as we've tried to reinforce over and over again, it's behavior. This is sort of falling into this bi-seasonal peak. So,
you know, flu does the same thing. Variants take over from season to season. Similar pattern, right? Yeah,
really similar. All right, vaccines. I mentioned we're going to be talking about vaccines, and apparently childhood vaccines have become political. Yeah, I joke about that because, clearly. So this week we have the article, Initial Effectiveness of mRNA 1273 Against SARS-CoV-2 Infection and Hospitalization in Young Children, published in, yes, one of my favorite journals, Open Forum Infectious Disease. And the objectives of this study were to assess mRNA 1273, that's Moderna, vaccine effectiveness against symptomatic SARS-CoV-2 infection and COVID-19 related hospitalization among children aged 6 months to 5 years during the initial 5 months of the vaccination campaign, as well as to determine whether the vaccine efficacy varied by age group. So 6 months to less than 2 versus 2 to 5 years. So here they included 572 test positive cases and 3,467 test negative controls. And receipt of the Moderna vaccine was associated with reduced symptomatic SARS-CoV-2 infection, which we care a little bit about, maybe me more than Vincent, but a 90% reduction in symptomatic COVID in these kids, and an 82% reduction in COVID-related hospitalization. Right. And we've talked about thousands of kids end up each year hospitalized with COVID. So this study, as they conclude, shows that Moderna's mRNA 1273 vaccine provided strong initial protection against symptomatic COVID-19, 90% vaccine effectiveness there, and against hospitalization, 82% vaccine effectiveness in children aged 6 to 5 years, once you start looking 7 days after that second dose. All right. On testing, just a little bit of a pause here on testing, right? It's the holiday season. You get cough, you get sniffles, you've got what you think is a viral syndrome, as we've been commenting for all. The only way to know what viral syndrome that is testing. There are no symptoms that are clearly discriminatory. Yeah, if you lose your sense of taste and smell and you're not congested, that might be COVID. You might retain your sense of taste and smell. That might be COVID. It might be a cough. It might be a sore throat. It might be GI distress. Unless you do that flu or that COVID testing, you don't know. And a lot of situations, it's really incumbent on patients to, unfortunately, inform their healthcare provider what that viral syndrome is through home testing.
Daniel, shouldn't we have a test that would simultaneously do flu, COVID, and RSV?
So we do. We have that, and actually we have that in a lot of our urgent cares in the region. There's also the Lucira combination flu COVID test that a patient can do themselves. They can pick that up at Walgreens or some of these other places.
But the urgent care test is a PCR test?
Most of the one we're using is actually it's an antigen test, but a lot of our hospitals have a rapid molecular test. Give us an answer in 90 minutes.
It would be nice to have a rapid antigen trio test.
I think it would be great if we had that for consumers, right? Yeah. The Lucira is actually molecular. It's one of these isothermal tests. Yeah. But I think that, it really changes everything. And, I recently saw this when you're in Africa And, if someone comes in and they're sick, if you don't have the ability to do diagnostic testing and you're relying on just your clinical judgment, you're wrong way too often. So really, providers really need help. We really need access to testing, even here in the US. So, all right. So let's say you do that testing and you test positive. I'll continue to leave in the links to the guidelines. But number one, right, we are still recommending Paxlovid, right? And remember, based upon that EPIC HR randomized control trial, 86% reduction in progression in unvaccinated individuals back during Delta predominance, and about an 80% reduction in progression to severe disease. Currently, Omicron vaccinated individuals, we have over 800 real-world efficacy studies there, right? So if you're over the age of 50, or if you have any risk factors for progression, why not reduce your risk of progression by 80%? And in some cases, consider it for prevention of long COVID. All right, number 2, remdesivir. That's based upon the Pine Tree data. That's also about 87% reduction of progression if given in the first 7 days, right? It is IV, so you may have to go to a place to get that. And molnupiravir, Thor's hammer, a little less impressive, but another option if there are drug-drug interactions or other issues. Convalescent plasma in certain contexts. And remember, germ theory. If you've got acute COVID, you can spread it to your friends. Same with the flu, right? You show up at that holiday gathering and you're sick, you feel crummy. Well, pretty soon everyone else will feel sick and crummy as well. And we're trying to prevent progression to the second week, that early inflammatory phase. Where in certain situations, folks end up in the hospital. And this is when there might be a role for steroids, anticoagulation, pulmonary support, remdesivir, immune modulation. And unfortunately, we're still, as I mentioned, still seeing folks progress here. And, last year we averaged over 100 deaths a day. All right. And a bunch today on COVID, late phase, past long COVID. In the MMWR, we have notes from the field, long COVID and significant long COVID associated activity limitation among adults by jurisdiction, United States, 2023. And here, CDC analyzed data from the 2023 Behavioral Risk Factor Surveillance System. I give a nice acronym, BRFSS. I don't know, but a large population-based cross-sectional survey of non-institutionalized U.S. adults aged 18 or older. These BRFSS sample participants used random digit dialing of mobile and landline telephones, and they're getting self-reported information here. Age, sex, previous COVID-19, current long COVID, significant activity limitation due to long COVID. And here, long COVID was defined as self-report of any symptom lasting for 3 or more months at the time of interview that were not present before having that COVID-19. And when they do the survey in 2023, 6.4% of the U.S. adults reported experiencing long COVID when surveyed. It's not great. It's actually a lot of adults if you start, taking 6% of the 350 plus million folks in the U.S. And you get different ranges. So long COVID associated activity limitation ranged at 12.8%, District of Columbia. You see at 29.4% in Puerto Rico. But among the 7 jurisdictions with current long COVID prevalence of greater than 8%, Idaho, Puerto Rico, and West Virginia were also in the highest prevalence quartile for significant long COVID-associated activity limitation. They have sort of a nice graphic here of an individual, huffing and puffing, trying to make it up the stairs. Got a woman here just trying to work on the computer and just not able to. And of course, the poor dad, right? His kids want to play with him, and he's just like sitting on the floor, just not able to even participate. All right, 2024 update of the Recover Adult Long COVID Research Index published in JAMA. Maybe people remember this. This is this index that can be used to really discern, which symptom clusters are coming from long COVID to sort of help us identify folks with this. And I won't go into too much, but it's really just an update where they compare this index, the 2024, now updated to the 2023, assigning different points, things like loss of smell or taste, the post-exertional malaise, the brain fog, chronic cough. And so I'll leave a link into that as well. But there was also a really nice piece in SIDRAP. I don't know if people listen to the SIDRAP podcast. I was listening to it today. This is out of University of Minnesota. And they covered, why do so many different studies give us different numbers on how many people are suffering from long COVID, and a lot of things they talk about that might, play into that. And they have a few nice quotations from Ziad Al-Ali, who's the Chief of Research and Development at the VA St. Louis Healthcare System. And I'll just read these off. Variation in incidence and prevalence estimates generally stem from variation in study designs. Are you using surveys of self-reported long COVID versus cohort studies? The definition of long COVID, is it narrow versus broad? What population is being studied? Predominant variant, vaccination rates, etc. I also note lack of any information on infection, he said in an email, because most people abandon testing, right? We talked about that. A lot of people get COVID without knowing it. They subsequently develop health problems that could be post-COVID conditions and cannot attribute them to an infection and won't be able to identify them as post-COVID. And he concludes, we entered a phase where post-COVID conditions are now intermingled with baseline disease, and consequently, it has become harder to detect through these kinds of surveys. All right, and a few more. A lot going on here in the long COVID section. Since we're still limited in terms of managing long COVID, the best thing we could do is prevent it in the first place. So we have the article building on this literature, Real-World Effectiveness and Causal Mediation Study of BNT162b2 on long COVID risks in children and adolescents, published in eClinical Medicine. So the Pfizer-BioNTech vaccine. Here we have the results of another real-world vaccine effectiveness study. They used data from 20 health systems in the Recover PCOR Net electronic health record program. 3 independent cohorts were constructed, including adolescents, 12 to 20 years, during the Delta phase, July 1, November 30, 2021, children 5 to 11 years, and adolescents 12 to 20 years during the Omicron phase, January 1, November 30, 2022. And the intervention is first dose of the Pfizer-BioNTech vaccine in comparison with no vaccine. The outcomes of interest included conclusive or probable diagnosis of long COVID following a documented SARS-CoV-2 infection and body system-specific conditional clusters of post-acute sequelae of SARS-CoV-2 infection, PASC, such as cardiac, gastrointestinal, musculoskeletal, respiratory, and syndromic categories. End up with pretty large numbers here. So you've got 112,590 adolescents, 88,811 vaccinated, included in the cohort for the analysis against Delta, 188,894 children with 101,277 vaccinated, 84,735 adolescents, 37,724 vaccinated when they're looking at analysis for Omicron. And what do we end up with? During the Delta period, the estimated effectiveness of the vaccine against long COVID among adolescents was 95.4%. During the Omicron phase, estimated effectiveness among children was 60.2%, and then 75.1% among adolescents. So really some compelling differences here between the protection against long COVID that we're seeing in children and adolescents. And what I really think is a big thing here, right? We already talked about the fact these vaccines can keep the kids out of the hospital. But what are most parents most worried about that their children will have lingering after effects of getting that COVID infection? And here, these are really dramatic reductions.
They're very impressive, and people should not question vaccination when you get numbers like this.
And this is interesting. I mean, this is a population which is clearly under-vaccinated. A lot of parents don't appreciate the protection that they can offer their children. So
one of the nominees for one of these healthcare positions has stated long ago that kids don't need to be vaccinated against COVID. So, this is just uninformed.
I think the tough thing is you can't just have an opinion and then just stick with it. We didn't know a lot many years ago, right? When one of these individuals was, writing the Great Barrington Declaration.
Yeah, that's what I'm referring to. The thing is, you go with what you have. You don't make stupid proclamations based on nothing, which is what you're saying, right?
Yeah, I mean, these are big numbers. These are great studies. And yeah, vaccinations in the kids can actually keep them out of the hospital. It can keep them from, requiring medical attention, which is over 100,000 kids last year. It can keep all these kids from ending up with long COVID and all the horrible impacts.
If you were unsure, if you don't have the data, you go to the default, which is to treat, which is to vaccinate.
Yep, one of the most effective, safest introductions in modern medicine. So, and just a couple more to finish this off before we get to our emails. 2 more articles. The article Personality and Neuropsychiatric Symptoms in Individuals Diagnosed with Long COVID, published in BMC Infectious Disease, where we read about the results of, this is an online survey with 114 participants diagnosed with long COVID. High rates of depressive disorders, 46%, generalized anxiety disorders, 21%, sleep disturbances, 76%, and not surprising, reported cognitive changes, 95%. And the article, Post-COVID Condition, Risk Factors and Symptom Clusters and Associations with Return to Pre-COVID Health, results from a 2021 multi-state survey published in CID. And here they reported, again, the high rate of long COVID in people who are infected in the pre-Delta period, and a high percentage that still have not returned to their prior health. So I will finish off, as I've been saying for a while, no one is safe until everyone is safe, and I'm going to include the animals. And I do want everyone to pause the recording right here, go to parasiteswithoutborders.com and click donate. I have to say, I've got to thank everyone who's done that, everyone who listens. This is a joint effort. It's not just me and Vincent here. It's all the people that help us find the important articles to discuss. And without your support, we couldn't continue. So we're going to continue our fundraiser November, December, January, and we're hoping to get up to a potential maximum donation of $20,000 for Microbe TV.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Brian writes, I work at a landfill in California. We are receiving truckloads of chickens that have been ground down into a fine material to make transportation easier. It's called detritus. This, of course, makes it easier to become airborne when it dumps out of the truck. We then spread this material with caterpillar dozers and mix it with other garbage into our landfill cells before covering it in dirt. I'm concerned for me and my fellow workers. Should I be concerned? Does H5N1 die quickly after the bird is killed? Anyone know how long it survives outside a host? Sound like we should, at minimum, be wearing N95 masks when these trucks arrive and offload the dead bird detritus.
Yeah, what a frightening. I feel like this is a sci-fi film in the making here, Vincent. Right? Just imagine like these trucks and this cloud, the plumes. So there is data, right? We have data. It's a little bit dated, but on H5N1 on poultry feathers, right? They do a lot of these, we'll call them fomite studies, right? I don't know, is a bird ground like this? Is it a fomite? Does it fall into that category? But yeah, no, it can last. It's temperature dependent. Of course, the colder it is, and it's getting colder in places, the longer that you can actually have viable infectious virus. So yeah, this just sounds like a recipe for aerosolizing and getting that into folks' eyes and lungs. And Vincent, thoughts from you? Would you wear an N95?
I definitely think they should be wearing N95s. Yeah. Because if this is being aerosolized, you don't know if it's infectious, but you should just be careful because it's a perfect scenario for getting infected. Yeah. So the truck drivers, the people at the landfill, when they dump it, and I don't know how long, I guess when they cover it with dirt, then you're probably okay. But yeah, you should be wearing these masks. Totally.
Yeah. And I'm just thinking like, how do they make the detritus? I'm just like thinking of the process of grinding these.
Yeah, wherever
chickens.
that's done, they should be
my
wearing
gosh.
masks too. Yeah.
Yeah. So, this is one of those, like, yeah, I would err on the side of wearing an N95.
Tom writes, is doxycycline a medication that qualifies as obfuscation of symptom-free for COVID-19 infection in the same way that acetaminophen complicates the notion of fever-free? A friend was prescribed doxycycline, rat negative, based on painful sinus congestion and a history of hard-to-control bacterial sinus infections. The anti-inflammatory quality of the drug was prompt and effective in reducing symptoms with the exception of a cough, post-nasal drainage. However, 36 hours later, tested rat positive for COVID. I expect that Hickam might remind the patient to keep taking and finish the antibiotic. The prompt involvement in sinus discomfort derailed discussions with the doctor about Paxlovid. A persistent cough and respiratory infection is, quote, trouble, in my opinion. What to watch for? How should doctors respond to cases where symptom progression is very effective, but the underlying disease progression is unknowable as a result?
Yeah, this is great. I mean, Tom, I love that $10 word, obfuscation. What a wonderful word. It's up there with crepuscular and a few of my others' favorites. But yeah, that's always a challenge. We always say, are you fever-free without, antipyretics? Are your symptoms improving without some sort of an anti-inflammatory? And then one of the challenges, right, with COVID is, it's like pancreatitis, it's like sepsis. The reason we recommend early treatment is that we have recognized that there are certain individuals, certain parameters that put a person at risk of progression. You don't just say, oh, you seem like you're fine. And I remember the acute pancreatitis cases, you tuck them at the end of the hall and they would not be alive the next morning. And that's kind of this issue with the second week of COVID. So yeah, this is a challenge. I think you point out some good things, but if this is an individual who is high risk of progression, you certainly want to have that Paxlovid discussion.
Daniel, do you like the word bespoke?
That's also a nice word.
Yeah, we had that in the title of a paper we did on TWiV last week.
Oh, I like that.
They made bespoke bat antibodies.
Oh, I like that.
Like you have a bespoke suit made in Hong Kong, well, you can make bespoke bat.
Yes.
Ellen writes, my grandson's age 2 with a cold and an ear infection, age 6 with a persistent racking but unproductive cough, were prescribed amoxicillin by their pediatrician, and both broke out with a red body rash. I understand that this may occur when there is a concurrent viral infection, but what is the connection between the antibiotic and the virus? Is it just this particular antibiotic that produces this non-allergic reaction? Then their pediatrician stopped the amoxicillin after 7 days and is prescribing a different antibiotic, which the parents are ignoring. Texas Children's Hospital website encourages continuation with amoxicillin and advises against switching to a different antibiotic as, quote, this can lead to the physician labeling them as allergic, thus leading to the patient being given different antibiotics, potentially causing more harmful side effects. What is the standard of care in this situation?
Yeah. So, it's really interesting. And we've been seeing this for a while. And unfortunately, I think what you point out is this is true. These kids often get labeled. And so, the kid has a viral thing. Classically it was mono or Epstein-Barr, and then they get the amoxicillin. And this rash develops. It's not an allergy. It's not a reason to avoid amoxicillin in the future. And it might be a reason for you to say they may not needed the antibiotic even to begin with. The mechanism that I don't really fully understand. What is it about the amoxicillin? How does it trigger this rash with the viral syndrome? So maybe some of our emailers, know the etiology there. They can let me know.
Karen writes, I have 67. I had COVID 3 times. First 2 times I took Paxlovid. Both illnesses were not horrible, but I was definitely ill. The third COVID came at an interesting point. A family friend, physician, 4 months older than me, just had COVID and advised not taking Paxlovid. He and his spouse both had COVID and did not take Paxlovid. Their illness course did not seem any worse than mine. I recently had my annual physical. My doctor also had COVID, did not take Paxlovid, and suggested I really did not need to take it given my lack of comorbidities beyond age. I planned to get the vaccine shot, but another friend came for dinner and brought not only wine, but COVID. This third time I did not take Paxlovid. The course of illness was not better or worse. My post-COVID experience seems no better or worse. Since I'm edging toward elderly, some say I am firmly in it. My memory isn't what it used to be. My trouble with finding nouns, always every present, seems no better or worse, etc. So a long message for which I apologize. I'm not sure what my question is as well, possibly. So the PAX or not the PAX? That is the question.
Yeah. So the guidelines are to PAX. And why do we say that? And again, every time you get COVID, it's a roll of the dice. It's a Russian roulette. I was fine the first 2 times. I was fine the first 3 times. But what happens that next time? And there also is a bit of an issue, and you bring it up, is with age, right? So we talk about the risk starts to go up at age 50. So let's say you use under 30 as your baseline. You hit 50, you're in your 50s, 28-fold increased risk of going to the hospital. Now you move into your 60s, your 70s. It really goes up dramatically as we get older. The other, and this is really interesting, and this is some stuff that I was reviewing in a study in Taiwan, is that in younger individuals, there really is this growing immune memory. But when we get older, part of immune senescence is that we don't actually get the protection. We may actually over time sort of get knocked down. So what we were seeing there in Taiwan was that the more senior individuals with repeated infections, their risk of bad outcomes was actually escalating as opposed to going down, which we have experienced in younger folks. So yeah, about 80% risk reduction of progression of severe disease if you take Paxlovid. So you're going to use sort of a risk, calculation here, number needed to treat. You mentioned no comorbidities. Hopefully you're active and ideal body weight, sort of throw that in there. But also potentially we might have some, impact upon long-term consequences.
And finally, Gary writes, I'm watching episode 1176 and I'm still confused about my own polio vaccination. I'm a 73-year-old male. I remember receiving oral vaccine as a young child, along with my siblings and parents. I never received IPV. Given concerns about vaccine-derived viruses in wastewater, more international travel in my retirement, and nutcases like RFK and his supporters who want to eliminate vaccines, should I consider a booster with IPV to reduce my risk?
All right, so maybe we'll each take turns here. So Gary, this is an interesting issue. What is the current recommendation? And so the current recommendation is you go through your series that we've talked about several times. And then if somebody is going to be traveling to what's considered a high risk situation, it's a recommendation for a 1 lifetime booster with IPV. And what is this based on? We've talked about this a little as well. Back when there was some circulating polio, people would get their shots, they would be protected, but maybe there was some kind of a boost in some of those earlier studies. The thing I have to say is, I've kind of looked for and kept my eyes out for, do we ever see anyone in their 70s, 80s, 90s end up having waning immunity and get polio? I mean, I haven't seen that. So maybe I'll let Vincent jump in.
All right. So, the recommendation is when you're young, you get a 4-course of IPV, right, Daniel? 4 shots. Yep. So if you haven't got a full course, either 3 of OPV or 4 of IPV, you should consider finishing it. That's the CDC recommendation. But if you got the whole thing, unless you're going to an endemic area, as Daniel said, you don't have to worry. Both IPV and OPV give similar durability of immunity to paralytic disease. Remember that. It's not to infection. It's to paralytic disease. So if you travel to Afghanistan, Pakistan, Sub-Saharan Africa, if you are traveling to those zones, you need a booster, but not to Europe or South America. You don't need a booster. Now, the U.S. is free of paralytic disease, but not virus, right? So when you say polio, it's very confusing because you can mean polio virus or poliomyelitis, right? You have to be really careful. You have to specify your terms. So the vaccines, IPV and OPV, prevent disease. They do not prevent infection. They do not prevent transmission. And so we have known since 1928 that the polio vaccine, that there was no vaccine in 1928, but infection can be followed by another infection, but you don't get paralysis. So it really depends on what you have had. If you can remember what you had. So I have records of having, you know, 3 doses of IPV and 3 doses of OPV later on. So I'm good to go. But if you haven't, you should consider following CDC guidelines. Does that sound good, Daniel?
Yeah, it's interesting because we bemoaned the fact that they had COVID-19 as a disease and SARS-CoV-2 as the virus and couldn't. Yeah, there's a certain advantage to their names as we see here,
true.
right?
But we do have polio virus and poliomyelitis. The problem is they both share polio, so people like to shorten it to polio, and then you don't know what you're talking about. You have to specify it, right?
Yeah, we should. They need to just say, because they always talk about we're going to eradicate polio, and it's like you can eradicate polio virus, which you don't seem to be doing each time you keep dumping all these doses of vaccine-derived polio virus into the community, or you're trying to eradicate poliomyelitis, the disease, and so
that's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, and everyone, enjoy the holidays and be safe.
Yeah, Happy New Year.